Decision-making under risk. The Irrational Physician. Welcome back. I have spent a good deal of time discussing the normative and descriptive theories of decision-making. Now it is time to apply these principles to healthcare and imaging, which I shall do in this lecture. I will introduce you to the difference between risk and uncertainty, explain the subcertainty effect, and probabilistic insurance. The overarching goal is to explain why imaging is utilized in low pretest probability scenarios. Notice, I am not saying overutilized, just utilized. It is best we approach this subject as non-judgmentally as can be possible. Let's recap prospect theory. Remember, it's not about absolute gains or losses, but relative gains or losses. Relative to a reference point. The reference point is susceptible to framing. If we consider ourselves to be in the gains domain, we tend to be risk averse. If we consider ourselves to be in the loss domain, we are risk seeking. And of course, which domain we consider ourselves to be is subject to framing. The power of the frame. Not many of us can claim not to have ever used the frame or being manipulated by the frame. Framing is the difference between optimism and pessimism, between that proverbial half empty or half full glass. Framing is particularly important and prevalent in healthcare. For example, radical treatment for cancer is more inviting when framed as 90% chance of survival rather than 10% chance of mortality. A central feature of the Affordable Care Act is waste avoidance, clearly a noble pursuit. But this can be demonized if framed as rationing. Mammography leads to overdiagnosis and saves lives. Depending on how it is framed, its value is either enhanced or diminished. Consider this example. A vaccine reduces the risk of a certain viral disease due to two strains from 20% to 10%. There are two explanations on how it works. The first is that the vaccine is effective in half the cases, rather randomly. The second, the vaccine completely protects against one of the two strains. The latter is more compelling than the former, even though the treatment effect is exactly the same. One of the key personnel to frame messages are radiologists. In our interpretations, there is tremendous potential for framing. We can tell clinicians what we see rather than what we don't see. The latter clearly has an effect on how they interpret the interpretation. One of the motivators for my introducing prospect theory so early on was to illustrate a fundamental tension in healthcare, of which imaging is only a byproduct. The tension is between maximization of expected utility, the standard utility theory, that policymakers wish to do, and the relative gains and losses that patients and providers experience close hand. Consider this example. A 70-year-old female with advanced renal cell cancer, of which a median survival is 6 months, is presented with a chemotherapy that has a 90% chance of instant mortality and 10% chance of extending survival from 6 months to 48 months. How would she choose? Let us assume that she is a utility maximizer and she wishes to maximize a utility, that is, number of months alive. In that case, she should forego the chemotherapy. Simple arithmetic shows that the expected utility of the chemotherapy is 4 months, 2 months less than her median survival. Let's now apply prospect theory. The reference point is her current predicament. If she views herself in the loss domain, then she will be risk-seeking. She will go for the chemotherapy. She will think to herself, nothing to lose, everything to gain. What might place her in the loss domain? Several things. She might not have accepted her diagnosis. She might have been given some hope by her oncologist. She might harbour hope herself. However, if she views herself in the gains domain, she is risk averse. She would reject the chemotherapy. What might compel her to think of herself in the gains domain? If she accepted her diagnosis, accepted that she would die, and wishes to die with dignity and enjoy whatever few days she has left. As you can see, what a dramatic difference the frame can make. There has been a lot of media attention on the costs incurred during the last 6 months of a person's life. Prospect theory gives you some basis to understanding those costs. Those costs also include imaging costs. Consider again a patient on chemotherapy that offers a slim possibility of slender extension in survival. That patient is admitted to hospital with a headache. Her team wants a head CT and MRI to exclude CNS manifestations of chemotherapy. The patient is not going to voluntarily forego these investigations just because death is imminent, because there is hope. So long as there is hope, high intensity of medical therapy will be tolerated, and imaging will continue to be utilized or overutilized. Okay, let's change gears and go back to some very interesting research in behavioral economics. There is an urn with 90 balls. 30 balls are red, 60 balls are either black or yellow. You don't know what proportion of black and yellow. It could be that there are 50 black balls and 10 yellow balls, or vice versa, or some other combination. You have to choose between a red and a black ball. The correct choice will yield $100. Most people pick the red ball because they want to avoid the uncertainty in the mix of black and yellow balls. There are 2 points to emphasize here. The first is that in picking the red ball, one is not certain of winning. One merely knows the probability of winning, which is 30/90. Note also that in foregoing the black ball, one has foregone possibilities greater than 30/90. It is true that one avoids possibilities less than 30/90 as well. The game has changed slightly. This time you get to pick 2 colors. If you get any of the colors you've picked, you get $100. If the urn yields a color you didn't pick, you get nothing. You still don't know the proportion of black and yellow. Your choices are red or yellow, or black or yellow. Most people pick black or yellow to avoid the uncertainty associated with the proportion of black. In doing so, they know the probability of winning, which is 60/90. Once again, they have foregone possibilities of winning greater than 60/90. This violates an axiom of the standard utility theory. That is the cancellation principle. If you pick red in the first game, you should pick it again in the second game. Why? Because in the second game the changes made were made equally to both options. If you pick a camcorder over a camera and headphone, you ought to pick a camcorder and a headphone over a camera and two headphones. This example of preference reversal is also known as Ellsberg paradox. Behavioral economists get very excited about Ellsberg paradox. It is another kick in the teeth of the standard utility theory. That is not why I am excited. I am excited because this example of ambiguity aversion is another road into the value of imaging. It shows that we have a preference for risk over uncertainty. Recall that aphorism by Donald Rumsfeld. He made a distinction between known unknowns, things we know we don't know, and unknown unknowns, things we don't know we don't know. We have a preference for known unknowns over unknown unknowns. Even before this Rumsfeldian aphorism, economists made a distinction between risk and uncertainty. Basically, risk is when you know the probability of an outcome that is neither certain nor impossible. Such an example would be the landing of a heads in a fair coin toss. We don't know for certain when it will land heads, but we know the chances are 50%. Uncertainty is when you don't know that probability. We prefer to be certain, but if we can't be certain, we would like to be at least certain about our uncertainty. Where does imaging come into all of this? Imaging can convert uncertainty to risk and reduce the bandwidth of possibilities. It can prognosticate. For example, if after clinical assessment the probability of pulmonary embolism is anything between 10% and 90%, imagine if imaging reduces that bandwidth of possibility to 40 to 45%. This reduction in bandwidth has value, even if we can't say for certain who has the disease and who doesn't. The challenge is to quantify this value and find scenarios of maximum uncertainty before the diagnosis and before the imaging. Okay, let's take a tangent here. Consider a lottery with a cash value of $300. The expected value of the lottery should vary linearly with the probability. By that I mean you ought to be twice as happy with a probability of 20% as you would with a probability of 10%. That makes perfect sense. Except that is not so. Look at the graph on your right. The straight line represents how we should feel about actual probability. The red line represents how we actually feel about the real probabilities. And you will notice that at the lower end of the scale, the red line is above the straight black line. What that means is that we value a change from 0 to 5%, a change of 5%, higher than a change from 30 to 35%. Stated differently, we value a change from impossibility to possibility higher than anything in the middle of the scale. This phenomenon is known as the subcertainty effect. Look at the red line again. At most levels, the weighted probability is lower than the real probability. This is of course in keeping with prospect theory, in that we are risk averse in the gains domain. In other words, the attractiveness of a positive lottery is reduced. This also explains the risk seeking in the losses domain, as the aversiveness of a negative gamble is also attenuated. But at low probabilities, this pattern is reversed. This means that the value of the long shots is enhanced. Now you know why people gamble. But it also amplifies the aversiveness of a small chance of a severe loss. You need to hold that thought because its relevance to imaging will be apparent very soon. So we have a preference reversal. People are risk-seeking when dealing with improbable gains and risk-averse when dealing with improbable losses. Okay, I'm going to emphasize another concept known as pseudo-certainty. Consider this two-stage game. In the first stage, there is a 75% chance that the game ends. There is a 25% chance that you move to the second stage. In the second stage of the game, you have a choice between a sure win of $30 or an 80% chance to win $45. Which one do you prefer? You must make your decision before the outcome of the first stage is known. I have written the expected values of the two options, and A has a greater expected value than B. Actually, it's the other way around. A has a lower expected value than B. Why then do people prefer A overwhelmingly over B? Perhaps by now you're not surprised by people acting irrationally. So let's change this game very slightly. When asked what people prefer, a 25% chance of winning $30 or a 20% chance of winning $45, most people seem to prefer D, the one with a higher expected utility, than C. But as you can see, B and D are the same in terms of expected value, as are A and C. Why the invariance? The invariance is because of the sure win of $30, even though that is in the second stage of the game and one does not get to the second stage of the game with certainty. This is an example of pseudo-certainty, where the sure gain is weighed higher than it should be. Before I tie all of this together for imaging, I want to explain a concept known as probabilistic insurance. This is very similar to the subcertainty effect. A lot of work in behavioral economics has taken place in the insurance world. There is a lot of similarity between insurance and imaging, in that we're dealing with partial information, risk, and uncertain outcomes. Let us consider an insurance that covers theft for the entire year. Let's assume that it costs a premium known as IP. Let's give a dollar value for that premium of $250. How much do you think people would be willing to pay for a premium that only covers odd days of the year? Now Mr. Spock, Homo economicus, would say that should be IP divided by 2. But in fact, people are willing to pay a lot lower than $125. Why so? This is because we value the elimination of risk from 50% to 0% far more than we do with reduction of risk from 100% to 50%. In a sense, this is intriguing because all protective systems are in a form of probabilistic insurance. That is, they reduce but do not eliminate the risk altogether. To recap, the relatively higher price of probabilistic insurance indicates that we value a reduction in probability of a hazard far lower relative to its complete elimination. We also tend to value a complete reduction of one hazard far higher than partial reduction of multiple hazards. So, do we have examples of probabilistic insurance and subcertainty effect in imaging? Of course. Sigmoidoscopy, which looks at the bowel from the rectum all the way to the sigmoid flexure, is undervalued relative to colonoscopy, which goes all the way to the cecum. Consider a patient who is at low risk for acute coronary syndrome and has a negative calcium scan. That dramatically reduces the risk of there being acute coronary syndrome but does not eliminate it. What about the soft plaque? This of course has consequences. In very low pretest probability scenarios, in order to completely eliminate or eliminate as far as we can the probability of there being an entity, a disease, we need to have a test with a very high negative predictive value. That essentially means a test with a very high sensitivity. As you know, sensitivity and specificity are correlated sort of inversely, in the sense that if you want more sensitivity, you lose specificity, and that increases the false positives. The subcertainty effect means that if the probability of PE is 0.2% or 98%, physicians may still get a test in order to get to 0% or 100% or as close to it as possible. Stated simply, we want to know for sure. Again, this has consequences. We tend to overvalue low probability events that are very disastrous to the patient, disastrous to the physician, and disastrous to the healthcare system. These entities could include acute coronary syndrome, aortic dissection, or pulmonary embolism. You can see here that there is a very good explanation, a plausible explanation for over-testing. So now we have these concepts of probabilistic insurance and subcertainty effect. So what do we do with them? Well, there are three things we can do with them. The first is to actually explain to policymakers why there is so much testing at low pretest probability scenarios. Secondly, we can counsel physicians by making them anticipate their behavior at very low pretest probability scenarios. If nothing else, it will reduce the magnitude of the subcertainty effect. Thirdly, we can quantify the magnitude of the effect in order to assign a value for imaging that disproportionately takes allowance of those very low probabilities. So we've taken a brief but important tour of medical decision making, or decision making in general, with applications to medicine. Let us remind ourselves of the normative. This is the ideal world. This is what ought to happen. This is a world inhabited by policymakers, economists, number crunchers, those that create economic models. Then there is the descriptive. This is the reality. This is what actually happens, with all the biases. This is the world inhabited by physicians and patients. Our job as radiologists is to bridge the chasm between the normative and the descriptive. Remember what this is called. It's called a prescription. Yes, strange as it seems, radiologists are prescribers. we have the dual task of getting physicians to think in terms of expected utility and of convincing policymakers that they should consider the outliers, the subcertainty effect, the probabilistic insurance effect. So we're in the midst of decision making. A lot of the value of imaging can be garnered from the literature in behavioral economics. Research in this area can open up non-traditional ways of valuing imaging. Thank you very much.